Now, in the second section of our lecture, let's talk about some other endocrine complications. In this, we will talk about the endocrine complications like parathyroid disease, pituitary tumor in pregnancy, and then also adrenal disease. So let's start with parathyroid disease. The fetal calcium needs every day is about 300 milligram per day. So the requirement of calcium per day is increased during pregnancy because the growing fetus required 300 milligram of calcium every day besides the normal requirement of the mother. So this is the increase in the level of requirement. So parathyroid hormone or parathyroid glands are present in the neck. Para means around. So parathyroid glands are present in the neck around the thyroid gland. So the name comes from parathyroid, so it's around the thyroid. Parathyroid glands function is mainly to increase the calcium level in the blood, and it is done mainly by the reabsorption of calcium from the bone, from the intestine, and then it is increased in the blood. So parathyroid hormone is responsible for the maintenance of level of calcium in the blood. So when the calcium level is low in the blood, parathyroid hormone or parathormone is produced, which is the hormone, and it causes reabsorption of calcium from the bone, and its level increase in the blood. And similarly, when it is increased in the blood, it causes deposition of the calcium in the bone. So main hormone responsible for maintenance of calcium in the blood is the parathormone produced by the parathyroid glands in the neck. So in the normal individuals, what happens, there is calcium intake. This calcium intake from our GI tract goes to the blood. Serum calcium is increased, and then from the serum calcium, as I said, it goes to the bone, deposited there if level is high, and then when the level is low, it is reabsorbed and comes back into the serum or blood. So that's why these arrows are both ways. They are deposited. Calcium is deposited on the bone, and then when required it is reabsorbed also. Similarly here, it goes to the kidney, and then from there it is excreted in the urine. But again, when it is required by the body, it is reabsorbed from the kidneys also. So both these are the both ways, both direction. One way to the bones and then back to the serum. And this is the normal cycle of the calcium, intake of the calcium from the GI tract, goes to the blood, goes to the bone where it is deposited, goes to the kidney where it is excreted in the urine, but when it is required in the blood, it can be reabsorbed and cause increase in the level of serum calcium levels. But now in the pregnancy, now 300 milligram per day is required by the fetus also. So naturally we need to increase our daily intake of calcium. We need proper functioning of the parathyroid hormone, and then usually there is increase in the parathyroid hormone to maintain that increased level of calcium required by the fetus. So in pregnancy, calcium intake, then its serum calcium cause same way goes to the bone and then goes to the kidneys, excreted in the urine, and then it goes to a big amount. You can see a big amount is going to the fetus here. So it is increased during pregnancy, and then to maintain that increase, we need the increased level of parathyroid activity. Pregnancy, there is increased renal loss, increased intestinal absorption, so we have to maintain that increased level, and that is being done by the increased absorption from the intestine. And then low serum albumin, we have corrected calcium. Normally, the low serum albumin causes decreased in the bounding calcium level, and that needs to be corrected also. So that's how the parathyroid or hormone or parathyroid gland functions in the pregnancy. Because we need increased calcium level, about 300 milligram per day, and that needs to be maintained by increased intake, by increased GI tract absorption, and then also, if required, by increased level of parathyroid activity. And if there is any abnormality in the production of parathyroid hormone, then the calcium levels gets very low, and this needs to be managed properly. Then another, hypothalamic pituitary adrenal axis in pregnancy. Hypothalamic pituitary adrenal axis in pregnancy. Hypothalamic is the endocrine system, which is the system of the hormones and the glands. Glands produce the hormones, and these hormones have different functions in the body. For the normal balance of the body, these hormones are very important. So hypothalamus in the brain, there is hypothalamus in the brain that produce different stimulating hormones that act on the pituitary gland. And this pituitary gland, especially the anterior pituitary gland, it has two lobes, anterior and posterior. Anterior pituitary gland produce in turn different stimulating hormones that act on different organs of the body. So in this case, hypothalamus is producing the hormone cortisol releasing hormone, and this cortisol releasing hormone causes production of ACTH. ACTH is the hormone adrenocorticotrophic hormone. As the name shows, adrenocortico, so it stimulates the cortical portion of the adrenal gland, which is present on top of the kidneys, and this in turn produces the cortisol in the blood. So this is the hypothalamic pituitary adrenal axis. Normally also the cortisol releasing hormone is produced by hypothalamus. This acts on the pituitary gland and causes production of adrenocorticotrophic hormone, which act on the adrenal cortex and produce cortisol. So now what happens in the pregnancy, there is increased in the production of creatinine releasing cortisol releasing hormone here. This cortisol releasing hormone is in the pregnancy also produced by the placenta. So placental cortisol releasing hormone causes production of placental ACTH, and then this placental ACTH has different effects, and this cause in turn we have cholesterol, which causes pregnenolone production, and this pregnenolone produce progesterone. Here, then progesterone has two effects. It causes conversion of dehydroepiandrosterone to 16-hydroxy dehydroepiandrosterone. Here also dehydroepiandrosterone is converted into androstenedione and testosterone. Then we have estradiol, then 16-hydroxy dehydroepiandrosterone. This converted into 16-alpha-hydroxy A4 and then estriol and then 11-beta-cortisol. So all these, finally the outcome or the summary of this whole diagram here is there is increased production of cortisol during the pregnancy, because besides the normal production of cortisol from the adrenal gland as a result of cortisol releasing hormone from the hypothalamus of the mother and the fetus, there is increased production of cortisol releasing hormone from the placenta, and all these can lead to increase in the level of cortisol, which is the steroid corticosteroid. So cortisol is increased during the pregnancy as a result of hypothalamic pituitary adrenal axis in pregnancy. So there is increased cortisol production, which also affects the increased pre-cortisol level in the blood. So this is the hypothalamic pituitary adrenal axis in pregnancy. Pituitary tumors in pregnancy. Pituitary tumors pituitary tumors like prolactin tumor, which is the tumor which develop in the pituitary gland, produce hyperprolactinemia. Hyperprolactinemia is increased level of prolactin hormone in the blood. So hyper is increased, prolactin is for the hormone prolactin, and it's increased in the blood. Hyperprolactinemia as a result of pituitary tumor in pregnancy, it is very important cause of infertility and amenorrhea. So if the female has pituitary tumor like prolactinoma or any other pituitary tumor that leads to increased production of prolactin hormone, this causes infertility and amenorrhea. So these women with pituitary tumor needs treatment and surgery for the removal of tumor so they can conceive and become pregnant. Due to benign pituitary microadenoma. Diagnosis is prolactin level measurement and CT or MRI of the pituitary fossa. So pituitary tumors like prolactinomas or can cause hyperprolactinoma or hyperprolactinemia, which can cause infertility and amenorrhea as a result of benign tumor known as pituitary microadenoma. Treatment of pituitary tumor is dopamine agonist, surgery or radiotherapy before pregnancy. So it's very important that any female who become pregnant, they usually pituitary tumors, they have difficulty in conception, they have infertility, but before pregnancy they should be treated with the surgery or radiotherapy. Cushing syndrome. Cushing syndrome is a syndrome in which it's rare in pregnancy and there is increased glucocorticoid production. So increased glucocorticoid leads to Cushing syndrome. It is due to hypersecretion of adrenocorticotropic hormone, ACTH. So hypersecretion of ACTH and hypersecretion of glucocorticoid can cause Cushing syndrome. And these are some very common presenting features, clinical features of Cushing syndrome. Usually patient have moon face, as a result of excessive cortisol. We talked about excessive cortisol. There is increased level of cortisol as a result of hypothalamic pituitary adrenal axis. And this high cortisol, if it's too much, even though it's rare in pregnancy, can cause Cushing syndrome. And this Cushing syndrome cause red cheeks, moon face, because of increased level of cortisol. There is osteoporosis. Bones become very weak and porous. They break very easily. There is easy bruisability, pendulous abdomen, red striae, thin skin is present, thin arms and legs, poor wound healing is present. So all these are very symptomatic features of Cushing syndrome, which is due to increased level of ACTH and increased glucocorticoid production. Tumors are most common cause that can lead to increased ACTH production. Then another syndrome is Conn's syndrome. This Conn syndrome is caused by adrenal tumor producing excess aldosterone hormone. So adrenal tumor also produce the adrenal gland produce another hormone known as aldosterone. So whenever there is tumor of the adrenal gland, it produces increased aldosterone hormone. And the effects of this aldosterone, again, it is rare in pregnancy. Common cause is due to common cause of secondary hypertension, high blood pressure. Because this aldosterone, what's the function of aldosterone? It causes retention of sodium and excretion of potassium. So increased sodium level or increased sodium concentration cause increase in the blood pressure. So it can cause secondary hypertension. Symptoms are hypertension and hypokalemia because it causes retention of sodium and excretion of potassium, and this excretion of potassium causes decreased level of potassium in the blood. And hypertension is mainly due to increased level of sodium. Diagnosis is high aldosterone, low renin, enlargement of adrenals, CT scan or ultrasound. Then Addison's disease. Addison's disease, again, autoimmune disorder. Diagnosis is difficult in pregnancy. Treatment of Addison's disease is glucocorticoid and fluid replacement. These are all the features that can occur in Addison's disease. Personality changes, anorexia, nausea, vomiting, pigmentation is increased. There is hyperpigmentation, or the color become very dark or blackish. There is hypotension, adrenal atrophy, which is due to autoimmune disorder, infection, and tumor metastasis. Diarrhea, abdominal pain is common, and muscle weakness is also present. So these are some features of Addison's disease, which is mainly autoimmune disorder in which antibodies are formed that causes destruction. There is requirement of glucocorticoid and fluid replacement therapy. Next is pheochromocytoma. Pheochromocytoma is rare catecholamine producing tumor reported in 1 in 50,000 pregnancies. So it's not common, but it can occur 1 in 50,000 pregnancies. So it's the tumor of catecholamine producing tumor, pheochromocytoma. This is the cortex of the adrenal gland. The outer portion of the adrenal gland is the cortex, inner portion is the medulla. So this pheochromocytoma arises from the medulla of the adrenal gland. This is the inner portion is the medulla, adrenal pheochromocytoma. This is the kidney and it is present on top of the kidney. The symptoms is patient have episodes of headache, diaphoresis or nervousness and anxiety. There is increased in the heart rate with hypertension. So all these are the features of pheochromocytoma. Now, pheochromocytoma, how we can manage if pheochromocytoma is present. If there is symptomatic pregnant patient, usually first thing to do is 24-hour urine collection for catecholamine levels. So urine is collected over 24 hours. That urine is measured for the level of catecholamines. And then MRI is also performed. If MRI is positive for pheochromocytoma, then we need further treatment. If it's negative, then we should look for any other cause of high blood pressure during pregnancy. And if it is positive, then we should start pre-operative blockage with alpha blockade and add beta blocker if tachycardia is present. So treatment is with initially alpha blockers and then we add beta blockers also. This treatment or management depend on what stage of gestation is pregnancy. If it's less than 24 weeks, we do resection of pheochromocytoma. And then if it's more than 24, then we do elective C-section delivery in third trimester, resection of pheochromocytoma, and then we recheck after 4 to 6 weeks level of catecholamine if they are low or not. So treatment depends on the time of pregnancy. If less than 24, resection. If more than 24 weeks, we should do elective C-section in the third trimester and then resection of pheochromocytoma. So pheochromocytoma is the tumor of the adrenal medulla that leads to increased production of catecholamines, and these catecholamines can cause hypertension, diaphoresis, and then it can cause other features also. So that was all about the different endocrine disorders and how they can be managed during pregnancy, in which we talked about the adrenal disorders and then we talked about parathyroid disorders and disorders like Cushing syndromes, Conn syndromes and Addison's disease. Thank you for watching sqadia.com.